Hi, I'm Dr. Kathleen Brennan, an assistant clinical professor at UCLA and the director of IVF at UCLA Westwood. Today I'm going to talk to you about in vitro fertilization protocols and procedures. In terms of the steps of in vitro fertilization, we first have ovarian stimulation, followed by oocyte retrieval, followed by the fertilization of the oocytes and the culture of the embryos, and then the embryo transfer, which could either be a fresh embryo transfer or a frozen embryo transfer. In terms of the fertility medications, we often start with oral contraceptive pills. The purpose of oral contraceptive pills is to help synchronize the follicles so that when we do actually stimulate the ovaries, the follicles grow at the same rate, so we have as many mature follicles as possible at the time of retrieval. GnRH agonists and antagonists are used to prevent the woman from ovulating too early, so that during the stimulation we can add these medications on in order to prevent early ovulation. The gonadotropins are actually the medications that are used to stimulate the follicles so that a woman will grow more than one follicle in a cycle, with the goal of having at least 4, but even up to 10, 15, or 20 eggs grow in a particular IVF cycle. First, there is the follicle stimulating hormone, which may be called Follistim or Gonal F, depending on the brand that's used. And this medication, again, will stimulate the follicles to grow. Human menopausal gonadotropins, or Menopur, is also used. Menopur has FSH properties as well as LH, or luteinizing hormone properties. So again, it's another medicine used in conjunction with the FSH in order to stimulate the follicular growth. HCG is another medication that we use to cause the final follicular maturation to occur and to then allow us to retrieve mature oocytes. This shot is sometimes referred to as the trigger shot in an IVF cycle. Estrogen and progesterone are then used for an embryo transfer, whether it's done in a fresh cycle or in a frozen embryo transfer cycle. And this is just to support the pregnancy and to help the endometrial lining become hospitable for an embryo. There are various protocols that we can use in order to obtain eggs via IVF. One of the protocols, in the older protocol, is called the Agonist or long agonist stimulation protocol. Here the M denotes menses, so that's when the period starts. And on the second or third day of the period, we'll start oral contraceptive pills in order to suppress the ovaries so that a follicle does not mature on its own. The GnRH agonist is the medication that will prevent the ovary from ovulating too soon. We don't want the woman to ovulate on her own. We want to control when the ovulation and that final follicular maturation actually occurs. Once the pituitary gland is totally suppressed by the GnRH agonist, we then come in with the gonadotropins in order to stimulate the follicular growth within the ovary. The injections are typically given for about 8 to 10 days, and once the follicles are mature, the patient would then be ready for the trigger shot. The antagonist protocol is the protocol that we typically use. Again, the M denotes menses, and we often will start with oral contraceptives. Again, the oral contraceptives are to help to synchronize the follicles of the ovary. We then take the patient off of the birth control pills for about 3 to 4 days in order to allow the ovaries to wake up a little bit and be less suppressed. And then we start the gonadotropins, so that is the FSH or the Follistim or Gonal F, and then the Menopur, the human menopausal gonadotropin. Those injections are given for about 4 days, and then the GnRH antagonist is actually added, again, to decrease the risk of the woman ovulating on her own before we would want her to. So again, the injectable medications are given daily, typically about 8 to 10 days in total. The follicle stimulating hormone, again, is either Gonal F or Follistim, and the human menopausal gonadotropin is Menopur HMG. In terms of what's required of the patient when they're going through an IVF cycle, in general, the patient is coming in for ultrasound and blood work about every other day so that we can monitor the follicular growth and also monitor the hormonal response or blood work to see how the ovaries are responding to the medication. So we do transvaginal ultrasound so that we can measure the size of the follicles, and we also do blood work typically to check for the estradiol levels during the stimulation. The estradiol levels should be rising appropriately, and we want to watch how this level is rising. By the end of the cycle, the estradiol level will be quite elevated, as each follicle that is mature will release at least 200 to 300 picograms per mil. So if you have an estradiol level of about 2,000, you would expect to have around 10 mature follicles. This is what an ovary looks like during the stimulation. As you can see here, there are multiple cyst-like structures. Each of these cysts is a follicle, which houses a microscopic egg. We can't see the egg because it's microscopic, but we use the size of the follicles as a proxy for the maturity of the egg inside of it. So here you can see an X demarking the measurement of the follicle. The ideal size for triggering of the follicle with HCG is about 17.5 to 18 millimeters in average diameter. And you want at least 2 to 3 of that size in order to think that the cohort is in general mature. So once the follicles have reached maturity, based on the size that we measure on the ultrasound, we then will give the trigger shot. Typically, the trigger shot is an HCG trigger shot, but it can be a GnRH agonist trigger shot as well if we use the antagonist protocol. The GnRH agonist trigger shot is used when an estradiol level is very high and a woman has had a very robust response to the IVF stimulation. This will help to prevent ovarian hyperstimulation syndrome. The transfer then can occur in that fresh cycle, or more commonly, we actually freeze the embryos once the embryos are made and do a subsequent frozen embryo transfer cycle. So in terms of the oocyte retrieval, you can see here a diagram of the female anatomy, and the ovary sits right in this region. Here's the transvaginal ultrasound, and we have a needle attached to this transvaginal ultrasound. The needle will then be injected through the vaginal wall and directly into the ovary. So here's an ultrasound picture of what it looks like when we're actually doing the oocyte retrieval. So the needle goes through the vaginal wall and into the ovary, and we direct the needle into the follicle. The follicular cyst is then aspirated, so the fluid is removed from this follicular cyst, which then pulls the oocyte along with the fluid. So here is a pictorial diagram, and you can see the follicle here, and here is the microscopic oocyte that's being suctioned with the fluid of the follicle.